Hello everyone and welcome to GastroVision. I am Dr. Qazi Suhail from Government Medical College, Srinagar. Today we are going to demystify the fundamentals of endoscopic ultrasound, the building blocks that every beginner needs to master. If you are a beginner struggling with basic anatomy in endoscopic ultrasound, then this video is specifically designed for you. Here is what you will achieve by the end of this masterclass. You will understand scope orientation and how images are visualized on your screen. You will clearly discern why certain structures appear on the left side of the endoscopic ultrasound screen while others appear on the right. You will understand the effects of clockwise versus counterclockwise scope rotation. You will confidently identify anatomical structures at different stations with various probe orientations. My advice is to watch this video multiple times. Repetition is the key to consolidating these concepts in your memory and building that muscle memory we all need in endoscopy. But before we dive in, here is one golden rule you must remember. All the movements you perform are transmitted accurately to the transducer only when your scope is straight, never twisted. Keep this in mind throughout your practice. Let's begin. When imaging with linear endoscopic ultrasound, rotational control of your endoscope is absolutely fundamental. Let me simplify the terminology. Rightward rotation means clockwise rotation and leftward rotation means counterclockwise rotation. When your transducer is pointing posteriorly, clockwise rotation allows you to observe the left side of your abdomen, while the counterclockwise rotation allows you to observe the right side of the abdomen. Think of it this way. You are sweeping the abdominal cavity in an organized, predictable manner. Now, let me share what I consider the most critical concept for beginners to master. When you perform a clockwise rotation, structures that lie to the right of your transducer will begin appearing from the left side of your screen, then move progressively towards the right side of your screen. I know this might sound counterintuitive at first, but stick with me. Let me demonstrate this at the GE junction station. When you perform a clockwise rotation here, the liver hilum is positioned on the right side of your transducer. As you rotate clockwise, you are essentially turning to face the hilum. Watch what happens. The hilum first appears on the left side of your screen. As you continue rotating clockwise, it moves from left to right across your screen. Remember this fundamental rule. On clockwise rotation, new structures always start appearing from the left side of your screen and travel towards the right. This is the concept that separates struggling beginners from confident practitioners. Practice this repeatedly. Visualize it. Once this clicks in your mind, EUS anatomy will suddenly make a complete sense. Now let's talk about how the transducer's acoustic beams create your image. The transducer emits acoustic beam across its surface. Think of your screen as a map. Structures captured by the caudal end, that is the tail end of the beam, appear on the left side of your screen. Structures that are captured by the cranial end of the beam appear on the right side of your screen. The practical implication is, as you advance your scope forward, targets move from left to right of your screen. Let me show you this video at the GE junction station. When you are facing posteriorly towards the aorta and you want to visualize the pancreas and splenic vessels, you need to advance downward. Watch what happens. As you advance, the pancreas enters the range of the caudal end of your transducer. It first appears on the left side of your screen. With further advancement, it travels from left to right across your screen. This is another cornerstone concept. Understanding this relationship between scope advancement and image movement is essential for confident navigation. Before we explore the various anatomical stations, I want to emphasize a strategy that will transform your endoscopic ultrasound examinations. Always choose a landmark. At every station, identify a reliable anatomical landmark. Then visualize all other structures in relation to that particular landmark. This systematic approach prevents you from getting lost and builds your spatial awareness. For the GE junction station, we will use the portal vein as our primary landmark. Now I am going to walk you through a step-by-step journey showing how different structures appear at different orientations. Let's begin our systematic exploration at the GE junction station. We will follow what I call the portal vein route. Why the portal vein serves as our guiding landmark, and we will visualize all surrounding structures in relation to it. When you first insert the scope with your patient in the left lateral position, as you pass through the diaphragm, you will image the lateral segment of the left hepatic lobe. The transducer position is pointing anteriorly. What you will see, the left hepatic vein appears as a beautiful tubular anechoic structure. Now let me explain the acoustic physics here. This is important. At this position, your acoustic beams travel from posterior to anterior. Starting from the transducer, that's posterior, first encountering segment is segment 2, the superior segment of left lobe. Then passing through the left hepatic vein, finally reaching segment 3. Here is something crucial to remember. Once you visualize the hepatic vein, you know your transducer is at the level of superior segments. Notice that the predominant part of the left lobe you are seeing here is segment 2. Now watch what happens when you push your scope down slightly. Segment 3 enters from the left side of your screen. Remember what I taught you earlier. Inferior structures always start appearing from the left. Keep pushing down and you will notice something important. The left portal vein enters your screen from the left. Why? Because the portal vein sits at an inferior level compared to the hepatic veins. The key principle is liver segments inferior to the portal vein level or the inferior segments. And yes, inferior means left side on the screen. For optimal visualization of the left portal vein, a downward push alone isn't enough. Add a slight clockwise rotation to see it clearly as an anechoic structure with hyperechoic bright walls. Now we are going to identify two important ligamentous structures attached to the umbilical portion of the left portal vein. These are critical anatomical landmarks. One is ligamentum venosum. What is it? The fibrous remnant of fetal ductus venosus. In fetal life, this structure directs oxygenated blood from umbilical vein to inferior vena cava, bypassing the liver sinusoids. On endoscopic ultrasound, it will appear as a hyperechoic curvilinear structure, a bright curved line extending from the left portal vein directing superiorly towards the heart. Remember, superior means right on endoscopic ultrasound screen. The anatomical significance of this ligament is it separates segment 2 from segment 4A. Another is ligamentum teres. What is this? It's a fibrous remnant of left umbilical vein from fetal life. It lies inferior to the left portal vein, which means left on endoscopic ultrasound image. It divides segment 3 from segment 4B of the liver. These ligaments are your anatomical friends. They help you orient yourself within the complex hepatic architecture. Our next destination is hepatic hilum. You will gently push your echoendoscope with a slight clockwise rotation. What you will see at the hilum is superiorly, that is right side of the screen, is the main portal vein dividing into right and left portal veins. Inferiorly is the main portal vein continuing its course. Alongside the portal vein, a globular anechoic structure, this is your common hepatic artery. Running parallel to the main portal vein, a tubular anechoic structure, this is your common hepatic duct. Here is important special relationship to remember. Between the main portal vein and common hepatic duct, the main portal vein is closer to your probe when examining from the GE junction station. Why? Because it is positioned more medially compared to common hepatic duct. Now, advance the scope while maintaining your view from hepatic hilum towards the portal vein. Keep observing the extrahepatic bile duct running parallel to portal vein. It's your constant companion throughout this region. As you advance your scope to follow the portal vein, something interesting begins to happen. The superior mesenteric vein starts entering your view inferiorly, meaning from the left side of your screen. The critical navigation step here is to visualize the portal venous confluence. To visualize the portal venous confluence, push your scope down towards the antrum while keeping the portal vein as your focal landmark. At this critical juncture, pay attention to the vertical relationships. The splenic vein will be at a higher level than your transducer, so it appears on the right side of your screen. Let me explain the acoustic path here. The acoustic beams travel in this sequence from transducer through the pancreas to the splenic vein to the portal vein, which lies posterior to the pancreas. The result on the screen is the splenic vein appears closer to your probe than the portal vein. Now push your scope down slightly while keeping superior mesenteric vein in view. What you will observe, the pancreatic shadow appears bifurcated, split into two parts by superior mesenteric vein. Part above the superior mesenteric vein is the body of pancreas, which is nearer to probe at this position. Part below the superior mesenteric vein is the head of pancreas. This superior mesenteric vein serves as a natural anatomical divider, helping you distinguish pancreatic body from the head. Now continue advancing your scope continuously, imaging from the neck of pancreas along the main pancreatic duct. Now your goal is to visualize both bile duct and main pancreatic duct in the area of major papilla. The main pancreatic duct will be closer to your probe than CBD. Why? Because at this position, acoustic beams travel from anterior to posterior. Main pancreatic duct is more anterior while CBD is posteriorly placed as compared to MPD. Observe the major papilla region carefully. Follow both the bile duct and main pancreatic duct as closely as possible. This is why these two critical ducts converge. After thoroughly observing the major papilla region, it is time to backtrack. Now slowly withdraw your scope while continuously visualizing main pancreatic duct. This allows you to observe the neck of pancreas in detail. This retrograde visualization helps confirm your anatomical understanding and ensures you haven't missed any pathology. At the neck of pancreas, turn your scope clockwise. What comes into view? The body of pancreas in its full glory. The splenic artery is imaged on the proximal side that's closer to transducer, while as splenic vein is imaged on the distal side that's farther from the transducer. Always use color Doppler and pulse Doppler to confidently differentiate splenic artery from the splenic vein. The Doppler signal makes vessel identification much easier and more reliable. The splenic artery typically shows a pulsatile waveform, while as the splenic vein shows continuous flow. Now continue rotating clockwise following the pancreas as far as the tail. What you will typically see, the tail of the pancreas extending towards the splenic hilum, the left kidney imaged on the distal side of the transducer. Sometimes left adrenal gland may also be visible in this region. The left adrenal gland can be tricky to identify, but when visible, it typically appears as low echoic structure with a characteristic shape, sometimes described as resembling a flying seagull or the Greek letter omega. Now turn your scope further clockwise to follow pancreas all the way to the splenic hilum. allowing you to observe the distal tail of pancreas. Angulating your scope slightly upward makes imaging the tail of pancreas and splenic hilum significantly easier. This upward angulation brings these structures into the optimal view. The splenic hilum marks the end of pancreatic journey, the point where the tail of the pancreas meets the spleen, with the splenic vessels entering or exiting the splenic parenchyma. And there you have it, a complete systematic journey through the GE junction station following the portal vein route. Let me summarize the key principles we have covered today. One is scope orientation fundamentals. Clockwise rotation means structures from the right enter from the left of your screen. Counterclockwise rotation, structures from the left enter from the right of your screen. Scope advancement, targets move left to right on your screen. Second is power of landmarks. Always choose an anatomical landmark. Navigate all structures in relation to that particular landmark. At the GE junction station, portal vein is your reliable guide. And last, the golden rule. Keep your scope straight. Always movements must be deliberate and controlled. Slow, methodical movements prevent you from missing pathology. Now at the end, your action plan. Here is what I want you to do next. Watch this video at least 3-4 times. Each viewing will deepen your understanding. During your next EUS procedure, continuously apply these principles. Start with the portal vein landmark and work systematically. Practice the clockwise and counterclockwise rotations deliberately. Watch how structures enter and exit your screen. Use color Doppler generously. It's your friend in distinguishing vessels. Be patient with yourself. EUS mastery doesn't happen overnight. It is built through repetition, pattern recognition, and deliberate practice. So remember, every expert endosonographer was once a beginner struggling with these exact same concepts. What separates those who master EUS from those who don't is consistency, deliberate practice, and systematic approach. You are not just learning to operate an endoscope. You are training your brain to think in 3 dimensions, to understand spatial relationships, and to build a mental map for complex anatomy. Keep practicing, stay curious, and never stop learning. If you found this masterclass helpful, please share it with your colleagues who might benefit. Subscribe to GastroVision for more educational content and leave your questions in the comments. I read every single one. Until next time, keep exploring, keep learning, and keep pushing the boundaries of what you can achieve with endoscopic ultrasound. Thank you for watching GastroVision.